everybody, and thanks for listening. Now, I know if you're like me, we are faced with what's the potential for national health, and we're all really concerned about it. And while at this point there's a lot of confusion and uncertainty about how it's going to play out and what's going to happen, I thought what I would do with this particular presentation is that I would come at NHI from a slightly different perspective. So just a little bit about me. My name's Julie Ellen Rowland. What's important for this particular talk is I'm a functional medicine practitioner. So just to familiarize you with the term functional medicine, basically what a functional medicine practitioner does is that we address your nutritional status, your lifestyle, the foods that you eat that you shouldn't be eating, the foods that you don't eat that you should be eating, your stress levels, your exercise, and how that relates to chronic diseases. So I will see people who have got conditions and are wanting really to address their bodies from the health perspective as opposed to from the disease perspective. Just the disclaimer before I even begin, everything that we discuss, questions, answers, the information that I present in this presentation is for informational purposes only. So if you have any chronic diseases, you've got any particular conditions, please discuss your conditions with your doctor, and please discuss anything that I mention at this particular talk with your doctor if you are wanting to make changes. So the challenges that we are faced are obviously issues like who's going to fund NHI, is it going to be effectively implemented, when's it going to be operational. Now, but I'm not going to go into that in this particular presentation. I'm going to address what is going to be the standard of practitioner and support care, given the fact now that there's going to be a brain drain, I would imagine, another brain drain, if NHI comes into being. And if the standard of practitioner and support care is going to be substandard, and I'm going to have problems either being treated timeously if I need it, or being treated well if I need to go into a hospital, and I'm uncertain about whether or not that's going to happen, what can I do about it? So the impact of NHI, really the only way that we can address the impact of NHI on ourselves at the moment, given all the uncertainties, is to minimize or eliminate entirely our need for medical care, either in a hospital or outside of a hospital. And we're actually in a fortunate position now because, first of all, we've got time, because I think it's going to take, I reckon, at least 5 years for NHI to roll out. So we've got 5 years at least to effect our own changes. And we are extremely fortunate because we've got the internet available to us. We've got opportunities like this where you can be addressed and be given a perspective of making changes in your life that will really create a huge difference in whether or not you're going to be sucked into using NHI hospitals. I need orthopedic lip gloss. At this time, our present health perceptions are, when we get sick, we are under the impression now that if we're sick, we definitely need medical professionals. And if we're going to go the route of medical professionals and hospitals and specialists, they always go hand in hand with our need for pharmaceuticals. At the moment, for most people, we're under the impression that we have no other effective options. But in actual fact, this is really, it's a myth. It's not true at all. I think we need to consider one aspect, and that is that if we believe that the medical model as it is now is all we have, then we also need to ask ourselves the question, is medical treatment safe? So if I'm going to be in a position where I have a chronic disease, I'm actually not so much speaking about, severe infections or trauma or car accidents where we, or hip replacements where we know that we cannot get away with the medical model or medical treatment as it is now. I'm looking at situations that I would call non-communicable diseases, and I'm going to address those in a little bit more detail later on. But if we look at, is medical treatment safe? I don't know whether any of you have heard the term iatrogenic. Iatrogenic basically means these are adverse effects caused by correctly prescribed medical treatments inside and outside of hospital. So this is different to medical malpractice, where you are given a treatment that's actually the wrong treatment. This is accepted treatment that has an adverse effect in your body. And in fact, iatrogenic causes of death are probably arguably the number one, even before heart disease and cancer. And even with those figures that put iatrogenic causes of death at number one, much of what is iatrogenic is unreported. Because, and one can really understand the perspective, if something happens to you in a hospital, or something goes wrong, or you get an infection in a hospital, or you have a poor response to a particular drug that your doctor prescribes, doctors are unlikely to take this further because they fear litigation. So because of this, sort of the true impact of iatrogenic causes really is not properly reported. Now, I just want to go through some interesting stats. I was really spoiled for choice on this. So, and I don't have statistics in South Africa or looking at South African hospitals. So the only statistics I could look at were statistics that are from American hospitals. But I think to some degree we can extrapolate those out. But in the United States of America, 80 to 25% of people who are recently ill actually are recently ill because of a medical or drug error or a medical drug reaction. Only 5.22% of medication errors are even reported. So when you take medication and there's a problem with your medication, most of the time no one even hears about these reports. So when you look at the package insert, and they might say a particular drug response is uncommon, if all the responses were reported, it might go from being classified as an uncommon drug response to a more common drug response, and we might think twice about medication that we actually go on. So in a 300-bed hospital, the number of errors per day was 40. So, and this is really a first world country, and you're still looking at 40 errors in a 300-bed hospital. So 4.7% of hospital admittance was from a serious drug reaction from a correctly prescribed drug. And the statistics showed that the worst reactions were with the SSRIs, which are antidepressants, the non-steroidal anti-inflammatories that are prescribed for arthritic pain or back pain or any exercise pain, for example, and the calcium channel blockers. Also, very interesting, of the 198 drugs approved between 1976 and 1985, most of which are still on the market in principle in a generic form or in the principal form, 102 had serious post-approved risks. So this is a very large percentage of the 198 drugs that were actually approved by the FDA. So one that shocked me the most was the chemotherapy. We know that chemotherapy is risky, but I don't think that we are informed as to how risky chemotherapy is. So what happened was 3,000 articles were examined on the value of chemotherapy in advanced epithelial cancers. In other words, cancers of the breast and the colon and the prostate. And they looked at, and this article was published in Clinical Oncology, so it wasn't published in Cosmopolitan. So they looked at the overall benefit or curative effects of chemotherapy to the 5-year survival. In other words, if you the chemotherapy so that you survive to 5 years or beyond. In adults, it was estimated to be a whopping 2.1%, which is extremely low. These are definitely not discussed with us before we go on to any sort of chemotherapy treatment. And I know that for me, when I read this, I just thought, how is this possible? Because I know, we all know people who've had breast cancer or prostate cancer or maybe colon cancer or one of the forms of cancer, and they've gone through chemotherapy and they're now living beyond the 5-year survival rate. So for me, I looked at this and I thought, how is this possible? But I think that the problem here is that there's no way of knowing whether those particular patients who survived would have survived anyway. So a statistic like this do show that when you're looking at medical treatment for our conditions, we really need to think very seriously about the medical treatment, because it's not as safe as we anticipate. Even when you look at x-rays or scans, are they safe? A CT scan, one single dose, is about 14 to 21 milligrams, and it's equivalent to being 1.5 miles from the blast of an atomic bomb in radiation. It's equal to 100 chest x-rays or 100 mammograms. And yet when a CT scan is recommended, we don't think a thing of it. We just, fine, we'll just go for a CT scan. So medical treatment has unreported and undocumented risks, even in first world hospitals. So if you look in South Africa, we ask ourselves the question, is it likely that statistics will be better or worse in South Africa? And we can answer those questions for ourselves. So how can we avoid medical treatment safely? If we can accept that medical treatment is not as safe as we think it is, and the process of NHI may increase the poor statistics here in South Africa. So what changes can we make that will afford the greatest blanket improvement in risks of conditions in our own health? So obviously, if we have a car accident or we get some severe infection, we're just going to go through the medical model. There's nothing we can do about that. But we can certainly address non-communicable diseases. Now, non-communicable diseases, obviously, as the heading states, they are diseases that you don't catch from each other. So examples of these would be anything to do with your heart disease or cardiovascular disease, cancer, Alzheimer's, Parkinson's, dementia, diabetes, inflammatory conditions, so rheumatoid arthritis, tendonitis, bursitis, irritable bowel syndrome, obesity and belly fat, and depression and mood disorders. There are others which I haven't listed here. Now, as things stand at the moment, we treat each condition as a separate disease with a different drug. But in actual fact, every single one of those non-communicable diseases that I've mentioned has something in common. They all have one driving force in common. And that driving force is a root cause, and it's insulin resistance. And insulin resistance is pervasive. It is getting worse and worse. So for us, if we address insulin resistance, we will basically address the root cause for all those chronic diseases and improve our chances of surviving, improving our, even if we do get it, improve the outcome of any one of those particular conditions. So if we look at the disease associations with insulin resistance, it's associated with obesity. We all know that one. Insulin resistance specifically it's a very, very strong association with metabolic syndrome. There might be people here whose doctors have diagnose them with metabolic syndrome. So they're on medication. They might be on statins for high cholesterol, high blood pressure meds, maybe on glucophage or metformin, and these all contribute to the syndrome called metabolic syndrome. Insulin resistance contributes substantially to the risk of cardiovascular disease as well as cancer. It's associated with type 2 diabetes. And insulin actually, so high insulin levels affect your mood and your motivation. So it contributes to depression, and it's strongly associated with Alzheimer's, any memory problems, poor concentration, and dementia. So if we want to address those, if we reduce insulin resistance, we will reduce our risks for a multitude of conditions. And the first thing to do is to start educating ourselves, which we're actually doing at this moment now. We need to make lifestyle modifications. We do not necessarily need medical intervention in these cases, although obviously there is a tipping point where over that tipping point we're going to need support, medical support. And addressing insulin resistance has a blanket effect, a blanket beneficial effect with all of those conditions. Signs of insulin resistance. So if you don't go to your doctor and you want to consider, am I somebody who is insulin resistant? What would be the signs? And the best one, and I say this to all patients, if you walk towards a wall and your nose hits the wall before your belly hits the wall, then there's a very, very good chance, if you're not pregnant, that you have insulin resistance. If you have that mid-afternoon energy slump where you're fine, you eat dinner, eat lunch, and then poops, you just have no energy, you just want to put your head on the desk and go to sleep. If you're sleepy after meals, if you have low blood sugar, so you have hypoglycemia where you get shaky and you get irritable and ratty because your blood sugar has bottomed out. If you have elevated HbA1c, this is a test that it's a blood test, and your optimal HbA1c, and I will address blood tests at the end of the talk, but your optimal HbA1c is 4 to 5%. And just to give you an idea how close these margins are, if you are 6%, you're already pre-diabetic. So if 5% or 4 to 5% is optimal and 6% is diabetic, you see how tight these margins are. Elevated fasting insulin, this is not routinely tested. Elevated glucose is tested, but elevated glucose is not very helpful because you can have normal glucose for 15 years and you are insulin resistant for 15 years. So one of the ways to check this is to look at your fasting insulin, and optimal is less than 5. And mood swings, anxiety, depression, anything that relates to your neurotransmitter balance, they are indicators of insulin resistance. The other dangers of insulin resistance are, one of the things is that insulin makes you fat. So if you're insulin resistant and you've got a lot of insulin flowing in your blood, you're going to gain weight and you're going to struggle to lose it. Insulin also damages the blood vessel linings, so that then you can start developing these little blockages. You get insulin resistance causes systemic inflammation, so it increases your C-reactive protein, your tumor necrosing alpha, your insulin-like growth factor, and all of these contribute to increased risk of heart problems. High blood pressure is another one. The other thing, insulin resistance, it initiates cancer through oxidative damage, so it increases your free radicals and it damages your mitochondria. And your mitochondria are little energy storehouses in your cells that put out your energy. So there's a very close association with mitochondrial cytopathy and cancer and insulin resistance. Cancer, in actual fact, cancer cells are obligate sugar metabolizers. Sugar is their primary source of fuel, and in fact the cancer cells have got increased insulin receptors on the cancer cells, so they will suck sugar into them at a much faster rate than normal cells. And in fact, specialists will use PET scans where they'll give you a radioactive sugar to see what's going on in your body as far as, the position and the size of tumors, because tumors are so sensitive to sugars and are so sensitive to insulin. Alzheimer's and dementia is another danger of insulin resistance, and fatty liver, and specifically non-alcoholic fatty liver. So what's happening nowadays is because the incidence of insulin resistance is going up, you might go along and have an ALT and AST and GGT blood test done, and you'll find that you've got signs of a fatty liver and you don't drink. So non-alcoholic, it's called NASH or NAFLD, non-alcoholic fatty liver disease, and it's worth checking because it's closely associated with insulin resistance, and your liver it's very important for, I think it's more than 600 of our metabolic processes. So what causes insulin resistance and how can we fix this? So insulin is a hormone, so it's a messenger. So our hormones basically rush around in our body and they message our cells to perform metabolic processes. Insulin is formed in the pancreas, and it's got two roles actually. The one role is that it transports glucose into the cell via the insulin receptors. So the insulin receptors that are on the outside of the cell wall, basically they are only receptive to insulin. They're not receptive to glucose, but the body needs the glucose inside the cell to provide fuel for the mitochondria. So what will happen is that the insulin will pick up the glucose in the blood and it takes it to the cell wall and it knocks on the cell, and the cell insulin receptor says, okay, this is fine. Insulin can dock. It docks on the receptor and the glucose can then travel into the cell via the insulin receptors. The other thing is, as a hormone, insulin's message to the body is to store energy. So often when I'm at the gym, I'll see people and they're walking on the treadmill. So they've come to the gym, it's fantastic. And there they are walking on the treadmill, and every now and again they sip their energy drink. And I want to go to them and say, you know what, you may as well have just stayed in the car, because the minute you sip your energy drink, and there's sugar in it, which all these energy drinks are loaded with sugar, even fruit juice, they're all loaded with sugar, your insulin spikes. If you've got insulin in your body, the message to your body is to store energy. And here you are at the gym, probably trying to lose weight, and you can't, because insulin says store energy, don't lose it. The other thing, insulin is an anabolic hormone. So anabolic is its growth, and growth is great if you're a bodybuilder and you want your muscles to grow. It's not great if you've got little pockets of cancer cells. You don't want insulin to cause any growth in those cancer cells. Our carbohydrates trigger insulin, and insulin also promotes the conversion of excess glucose to fatty acids. So insulin makes you fat. It also assists in your protein and your fat metabolism as well. The causes of insulin resistance: what we eat, how often we eat. So I am definitely not a fan of 6 small meals a day, because if you follow the 6 small meals a day plan, it certainly does balance insulin, but it balances insulin way up here. So if you are eating 6 small meals a day, you've got insulin in your body all the time. And what's going to happen is that you're going to develop a situation where your cells are so constantly bathed in this insulin that eventually it's a little bit like we switch off when our children nag us. We just don't hear them anymore. The receptor sites, because of their constant exposure to insulin, they shut down. They're no longer receptive to insulin. And that is the condition of insulin resistance, where the insulin is there, but it's not getting into the cell, it's not docking on the cell, and it's not able to transport the glucose into the cell because those insulin receptors are now, they've said, enough, thank you, we're done with insulin. Genetics plays a role. You can actually test to see what is your status in your body with genetics. Genetics is now affordable. I work with genetics all the time. It's more affordable. Stress is a big issue. Sleep deprivation, nutrient deficiency. So magnesium deficiency, for example, is a biggie, because Magnesium allows the insulin receptor to hold its position. So it's a little bit like the Starship Enterprise, and you've got one of these little outside ships. They've gone off to little foray and look at other planets, and they come back to the Starship Enterprise, and they now want to dock on the receptor site. And the receptor site needs to be a perfect fit. If you are deficient in magnesium, the receptor site gets a bit squonky, and now the insulin can't dock on the receptor site, so you don't get a smooth transition of the glucose into the cell. Now, what you can do, the small changes, big impact. This is what we can do to make a huge difference. Cut out carbohydrates. Now, vegetables and salads are also carbohydrates, but the body responds in a completely different way to vegetables and salads. So by carbohydrates, I'm talking about bread, pasta, sugars, biscuits, rice, potatoes. And people will say to me, but rice and potatoes are natural. Yes, they are. But the body cannot tell the difference between the glucose in a potato and a tablespoon of sugar. Your insulin responds the same way. So the first thing is to cut out carbs. The second thing is to eat 3 meals a day, not 6 meals, because when you eat 3 meals, you have time between your meals for your insulin to drop out. In other words, your insulin is now finished, it's done its job. So you have a few hours where you have no insulin in your body, and it allows the cells to cool from that insulin response. Intermittent fasting. Now, I've highlighted intermittent fasting. If there's one thing, please, that you walk away from this talk tonight, and that is to start intermittent fasting. If we've got time at the end, I will address how to do intermittent fasting. I'm hoping questions will come up, so please remind me on that one. But it will really is the one thing that you can do that will make such a big health difference to you into your future. Exercise to reduce the stored glycogen in the muscles. You need correct supplements, and to get proper sleep is very, very important, because poor sleep habits and not enough sleep increases your stress response, it increases your cortisol response, and it causes insulin resistance. So what happens with the stress response is that when we are stressed, our body releases adrenaline, and every time our body releases adrenaline, it releases cortisol as well. So we go into a flight or fight response. Now, if we're being attacked by that dog, of course, your body knows, whoa, quick, release sugar into the muscles because you're going to use them because you've got to run away. But when you're in a state of chronic stress, your body doesn't know the difference between that dog and between chronic stress, and your body releases glucose into the muscles because it doesn't know. I mean, you have to run away from this. And as soon as glucose is released into the bloodstream, your body effectively has a snack. This stimulates insulin. Insulin stores fat. Your body is exposed to insulin all the time, and you develop insulin resistant. So a parting analogy is, if you were going to build a city, in order to build the city and for the city to be effective, you need a power plant, you need solid walls, you need a Department of Defense, you need an effective sewage system, you need, in this day and age, Wi-Fi and internet, you need good roads, you need efficient city employees, it would be nice, and you need some sort of a parliament. So the body works exactly the same way. In the body, our power plant is effective mitochondria. Our solid walls, we want good wall structures. Our Department of Defense is our immune system. We want an efficient Department of Defense. Effective sewage system, we don't want it to be constipated. We want all the toxins to actually be eliminated from our body. Wi-Fi and internet, we want our nerves to be functioning properly and our neurotransmitters to be functioning properly. Good, clean roads is our blood supply and our lymphatic system. Efficient city employees that are going to mastermind all of this are our enzymes, and a parliament is, of course, our brains. And the one thing that is going to erode the whole city are termites. We know that in a city, if we get termites in, then the whole city crumbles. And insulin resistance works like termites in our body. It basically causes a collapse and a crumbling of our system. And if you had this gorgeous car, if this belonged to you, would you put substandard fuel in this car? Of course not. And yet we do it to our bodies all the time. And if you had this car, you would definitely, this car would go for a service every single year. and yet we don't service our bodies. So what I would like to suggest is that basically you start servicing your body, and once a year you go for the following test. You get your HbA1c tested. The margins need to be 4.5 to 5%. Fasting insulin, please request a fasting insulin. It's not routinely done. It's not an expensive test either. That should be less than 5. Fasting glucose, they do all the time. To be honest, I sometimes think fasting glucose is a little bit of a waste of money. Homocysteine is out of the parameters for this particular talk, but it is extremely important for your heart risk. Ferritin, in other words, what is your iron storage? Iron is very inflammatory. So you want your ferritin to be between 90 and 100, particularly for men and for postmenopausal women. We're holding on to our ferritin, so our inflammatory process is going up, and chronic diseases are fundamentally inflammatory in origin. High sensitive C-reactive protein, you need it to be 0.5 to 1. High sensitive C-reactive protein measures the inflammatory markers in the blood. It's very, very telling. Vitamin D between 50 and 60, and get your thyroid checked as well. So thank you for listening. If you've got any questions, please feel free to contact me.